So good morning. Thanks, Val, for inviting me back to update everyone on a project that I was here to present on 2 years ago. And at that point, we were just at the preliminary stages. We weren't really in the midst of it. We were very early on, just in the beginning of the data collection. So, and I think we were trying to use that meeting as an opportunity to do a little bit of consultation. So I'm here to give you an update on what came out of the review that we did, and also answer any questions, and hopefully some of what we learned will be helpful as you guys move forward with the ODAP. What I do want to mention is that I am here on behalf of a very large research team. The very last slide in the presentation just lists the entire team. I'm not going to go into that right now. So some of that team is in the room. So Paul and Lynn and Kevin participated, as did Victoria, and I know she's not here today. But we also had researchers from BC, Quebec, and Newfoundland involved. So if you have any really difficult questions, I'm going to defer to the experts. My role on the project was as project coordinator, so I was really the one who was herding the cats and making sure that that the review went forward on the timelines that we were working on. Also, just want to acknowledge that this was a project that was funded by WorkSafe BC. The final report, the rather lengthy final report, went in with a very large thunk on the desk of the funder. And we have asked them to hold off on making it publicly available so that we can write a publication. We're working on putting together a publication for the American Journal of Industrial Medicine. So today, what I want to do is just walk you through what we did, give you a sense of the findings, and then leave you with a few key takeaway messages. So, starting out why we did the project. The rationale for the project, I think, is not surprising to anyone, or won't be new to anyone in this room. Michael, right? Did I get your name right? Yes. As Michael mentioned earlier, he alluded to the fact that occupational disease is very prevalent. It's a high burden. So the reasons that informed the development of the project and the request for funding that went into WorkSafe were reasons like occupational and work-related diseases are mainly, or sort of still remain relatively invisible compared to occupational injuries. The WHO estimates that occupational diseases kill 6 times as many people per year as occupational injuries, and there is some Canadian data that suggests that actually might be an underestimate, and that might be much higher than that. And as was pointed out by Paul, that although they're largely preventable, occupational diseases still continue to be very prevalent, and there's a very high cost to both sort of in terms of human costs as well as social and economic costs. So what we did, our primary objective on this project was to set out to identify prevention strategies that were either what we defined as promising or that appeared to be effective to prevent 4 occupational diseases. And they tie in with the diseases that are on the Occupational Disease Action Plan. So we looked at noise, we looked at occupational cancer caused by 4 different carcinogens, we looked at contact dermatitis, and we looked at asthma. The main reason that these diseases were chosen is that they represent common occupational diseases that have been associated with a high burden of illness. They included ones that we presumed would be well studied with respect to prevention and interventions. And they were associated with specific and or known work exposures that we believed would be amenable to prevention. In a nutshell, what we did was a scoping review. So what that means was we did a search. We used a number of defined search terms searched the literature, collected what came out of the searches, and then went through a screening process to narrow down the studies that we were going to look at. We didn't systematically weigh the evidence. This was not a systematic review. What we wanted to find out was, let's just find out what's out there. And the idea being that this could at some point form a foundation for a systematic review in the future. The other part of the project was that we supplemented what we learned from the scoping review with key informant interviews. And we asked our research team, the research leads, for names of experts in the various subject areas, and we received 27 names that were put forward, and in the end I approached 21 people and 14 experts agreed to participate. So we supplemented what we learned from the scoping review with information from these key informants. And I'm going to touch on that as we go through. When I'm going through the findings of what we learned in the scoping review, I'll highlight some of what we learned from the key informants as well. So how we collected our data is just kind of captured on this slide. And so on the left-hand side, what I've tried to demonstrate for you or display for you is just the sheer volume of information that we collected. Based on the search criteria, over 42,000 articles were identified. And of these, about 16,000 were in the peer-reviewed literature, and the vast majority of those, or the weighting of those, was kind of weighted towards the noise-induced hearing loss literature. About 26,000 articles were identified in the gray literature, and that was heavily driven by the articles in the gray literature about asbestos. Once we applied our criteria, our inclusion criteria, we ended up with just under 700 articles that were retrieved. And again, noise-induced hearing loss accounted for half of those articles. We retrieved about 384 noise-induced hearing loss articles. And then based on the time that we had available, the team that was in BC, that Hugh Davies and a research assistant, they applied some other criteria to decide that they were only going to be able to look at 120 articles. So in the end, across all of the diseases and the carcinogens, what we looked at were 404 articles. And the box that's on the right just gives you a sense of the kinds of questions that we were kind of looking at as we were filtering out the articles. So we were looking at questions like, is this a program? We were capturing information on like whether the program had been evaluated, whether the program had been implemented. So if it was an idea that had been studied just for the sake of research question, exploring a research question, we were more interested in whether the idea had actually been implemented. And then one of the other questions we were interested in, and this is not something I'm going to go into any detail today, is we were also applying a lens of, are these prevention activities, are they relevant to what we were referring to as the Canadian context? So taking into account that there are differences in how occupational health and safety is kind of applied and managed across the country, as well as we were looking at whether they addressed populations of interest. We were also really curious to explore the question of the precarious workforce. So we were looking at that as well. The main areas that these, or countries that the studies came from, we focused on Canada, the US, Europe, Australia, and other developed countries. And although our main focus was primary prevention, that was one of the lenses that we applied to the data. We it did include articles that were focused on secondary prevention if there was some evidence that the information was being fed back into some sort of a prevention loop. The only other thing I wanted to just add is that of the 404 articles that we reviewed, approximately half of them had been evaluated. So we looked and kind of synthesized the information from all 400 studies, but just to kind of acknowledge that And this was a gap that we identified in terms of the research, that there really is a scarcity of well-evaluated studies on prevention out there. So just to give you a sense of how the numbers of studies broke down by disease, and then sort of thinking about, sorry, I'm looking at this from my right and so on your left is the breakdown by disease. You can see so blue is noise-induced hearing loss. The lighter blue is contact dermatitis, and then we've got asthma and cancer. And you can see that proportionally, cancer, asthma, and noise-induced hearing loss, there was approximately the same number of articles that we retrieved. And then when I pulled out the number of articles that fell into the occupational cancer, what we decided was the lens, even though we were kind of we intended to look at occupational cancers, what we were focusing in on were carcinogens. And so we looked at asbestos, diesel exhaust, silica, and shift work. And then the little graph on the right just gives you the breakdown of how those studies kind of fell into those categories. Asbestos was the largest driver of the number of studies that we found under occupational cancer. Silica and shift work were approximately equal, with diesel coming kind of at the bottom end. So before I go into the results, what I wanted to do is I'm going to put up kind of a model of primary prevention. I sort of had to think about when I got the information back from all of the various groups. So we had the asthma group was in Newfoundland. We had the occupational contact dermatitis group here. We had the cancer group here. Paul was leading that, and the noise-induced hearing loss. So I was getting information from teams in very different ways. And as we were looking at the information and trying to figure out how do we synthesize this vast amount of information into a coherent narrative, what I decided, I kind of looked at it from different lenses. And so I'm about to kind of walk you through the lens that we ended up presenting the information in. So what I was thinking about, or we as a team also were thinking about, was, how do we group these primary prevention activities? And so considering them, what are they, and then who would have primary responsibility for them? So the first kind of frame is thinking about the kinds of primary prevention activities that take place in the workplace. So I grouped the information under category of control measures, and then also education and training. Those would generally be taking place kind of on the front line. And then moving upstream, we defined a number of activities under kind of the regulatory framework or regulatory regime that would include legislation, regulations, and policy, both with the thought that is the kind of activity that mandates or drives these other activities in the workplace. And then finally, surveillance, which we've just heard a lot about. And the thinking there is that and the arrows that are kind of coming out highlights that that information is there to inform both prevention activities in the workplace, as Paul was suggesting, as well as ideally informing legislation and regulations so that they're evidence-based or evidence-informed. And then finally, legislation and regulations can mandate surveillance activities. The one example that I'm most familiar with is, I'm from BC, so in BC, and I used to work for Workers' Compensation Board. I actually worked in the regulatory review process. So one of the things that we had embedded in, or had and still have embedded in our regulatory framework, is the requirement for hearing tests. If workers are exposed to noise above a certain level, there's a requirement that employers do hearing tests. So there is an example of a kind of surveillance that is mandated by legislation. So this then is the framework that I used to organize the results, and this is how I'm going to walk through them today. And then one of the things that, as I started to go through the results and try to kind of make sense of it, was the realization that there are some that didn't fall into neatly into either of those four categories. And so we came up with a category of multifaceted approaches, and they can take into account, two of those categories, or three or more, or all of them. So as I go through the results, I'm going to just kind of hit the high points and give you some examples of the findings as they fell into these categories. The other lens that we were looking at was, in terms of thinking about whether they were evaluated studies and thinking about whether they were effective prevention strategies, was looking at whether or not they had any kind of demonstrated impact on exposure, health, or behavior outcomes. So, jumping into the noise-induced hearing loss. On the left, I've used the same approach for all of the slides. So on the left, I'm trying to give you a sense of kind of the volume of information that we were working with, and then on the right, just at a very high level, what we learned, what our main findings were as they fell into each of those five kind of categories of prevention. So the majority of the studies that were identified, as I mentioned, from the peer-reviewed literature, were in the noise-induced hearing loss category. We retrieved 384 articles, but in the end we reviewed 120, and of those 120 articles, just over half of them had included some measure of evaluation. What you can see here is that we identified studies in all of the five prevention, what I'm referring to as clusters, the clusters of prevention activities, and that's not the case for all of these diseases. The majority of the studies that we identified were hearing conservation programs, and what I chose to do, and people can argue with whether this was the right decision or not, I treated hearing conservation programs as a multifaceted intervention, as opposed to something that would fall under the legislation and regulation. I realize that hearing conservation programs are often mandated by legislation, but the way in which the results were interpreted, and certainly interpreted by the team, it made sense to put them into the multifaceted category. So what we found was that all but one, so there were, I'm not going to tell you, and if anyone has any questions about it, I can kind of tease out that information about the number of studies that we identified in each of these categories. But looking at legislation, what we found was that almost all of the studies that we identified or that we categorized in as legislation or regulation were focused on exposure outcomes, so noise levels. And the findings were mixed. So we had some studies that found that regulations were ineffective because of an over-reliance on hearing protection as opposed to control measures. And then others found that engineering controls that did measure noise levels routinely, that they still exceeded permissible limits, sometimes despite the presence of these engineering controls. So we were finding some studies that were positive, that were kind of noting a positive effect of regulations, and others that noted that the regulations were not as effective. The key informants also noted this, and one of our key informants was a noise expert, and he commented on how the OSHA noise standard has been enforced. And in some cases, what people were pointing out to us was that the regulations themselves are or can be effective, but there are some issues in terms of how they're enforced. So most of the, I'm going to jump down to the third category of studies, so the exposure control studies. Most of those studies were focused on examining the impact of exposure control in the workplace. So they were either, what they found were that engineering controls, either on their own or in combination with other prevention activities, were effective at reducing noise exposure. One of the things that emerged from this part of the project, and we did see it in others as well, was in relation to the education and training, that we were finding that they were effective. It was an effective strategy, but often the impact depended on the context. So, even within an industry like, say, for construction, there were a lot of studies that were conducted on the impact of education and training on noise induced hearing loss, but what we were finding was that even within an industry, and I recognize that construction is heterogeneous, that they were finding that yes, it was effective at changing behavior, but the impact actually depended on things like the manner in which it was delivered. Was it delivered by a person? Was it delivered kind of using kind of web-based tools, those kinds of things. So those were factors that influenced the effectiveness of this particular strategy. And then finally, on this one was there were mixed findings around the effectiveness of hearing conservation programs. And the one study that this team flagged in particular was a systematic review of the literature that looked at 19 studies, and only 4 of those 19 studies showed that there was a clear benefit to hearing conservation programs, and the other evidence that they reported was sort of, in some cases that yes, it worked, and in others that it was less effective. And then we did have some other multifaceted studies that weren't categorized as a hearing conservation program, but they adopted elements of other prevention strategies, and that they were shown to change behavior in terms of the willingness and the readiness to adopt using hearing protection. So moving on to contact dermatitis, and if you have any tough questions on this, I'm going to defer to Lynn. So the industries that were studied here, or that we had articles on, included construction, building trades, metal workers, and wet workers, so hairdressers, nurses, and other healthcare workers. One of the things I want to point out here is that this was the one disease where we saw a very high proportion of the studies that had been evaluated. So these methods, prevention methods, they evaluated them for effectiveness. So in terms of studies that looked at the impact of legislation and regulations on health outcomes, they found for the most part that these interventions had a positive impact. So there were studies that were coming out of the United Kingdom that were looking at the effectiveness of regulations restricting exposure to latex, chromate, and nickel. Some of those studies found that the chromate directive had been successful, and then there was some mixed evidence or some questions about the findings of the nickel directive in the EU being less clear, saying that there may have been a partial failure of the regulation, but they didn't. There was another study that said that they felt that it was effective, so the evidence on that was a little bit mixed. In terms of surveillance, the surveillance studies that were retrieved were focusing on health outcomes. They weren't looking at kind of hazard surveillance or exposure monitoring. And the findings of the articles that were retrieved and examined were mixed as well. One was a review article that concluded that there was no direct evidence of the effectiveness of health surveillance in the early detection of occupational contact dermatitis or occupational contact urticaria, or on the comparative effectiveness of different screening methods. And then on the other hand, there was another study that found that a tool to screen for work-related eczema was effective. So we were sort of seeing some mixed findings. And as I said at the beginning, this really was just a scoping review where we were just looking at kind of what was out there. We weren't trying to weigh whether one of these studies was a better study than another one. We were just seeing what was out there. The exposure control studies, what we we noted, or what we identified, was that they were reporting positive health outcomes with the elimination of exposure and the use of personal protective equipment. There was a systematic review that was that we found that examined the evidence for the use of personal protective equipment and personal hygiene measures, and they concluded that there were some positive effects of things like barrier creams, moisturizers, after-work creams, that kind of thing. The findings on education and training, most of the studies that were identified in this area were based on the Danish skin protection program, and they found that they were effective, those particular approaches were effective. So that these types of educational interventions increase knowledge about skin hazards and improved work habits. And there's if anyone wants to come up and has any questions, I can give you the examples of what those were. I won't kind of use up all the time. And then studies examining multifaceted approaches to preventing contact dermatitis found that they also had positive effects in terms of decreased symptoms and positive behavior change. And I just realized I'm going to be the person who's going to be keeping you from your stretch break, so I should probably speed this up a bit. The next 4 slides look at the cancer results, and so starting with asbestos, we found, you can see here that we found studies in 4 of the 5 clusters. And so one of the things I should have mentioned at the beginning was that one of the criteria that we used to kind of narrow the studies was we looked for studies that had been published between 1996 and 2016. So in some ways, it didn't surprise me that we didn't find any studies looking at controlling exposure to asbestos, because I think that most of those studies would have been published well before 1996. What we found in terms of the legislation and regulations, or the studies that fell into that kind of regulatory framework, was there were 2 studies, 2 articles. One was a review article and one was primary research. And they found that a legislated ban on asbestos exposure was effective at reducing asbestos-related disease. In terms of surveillance, we identified one study that was an Italian registry for mesothelioma, and they were identifying that it was useful for identifying cases and informing their prevention efforts. We also flagged one other study, and this was less about kind of health outcomes. It wasn't an evaluative study, but there was an article on asbestos surveillance that was focusing on kind of the creation of the building registry in Saskatchewan, and we felt that it could or should be included because it did offer some information on how to influence policymakers on how to create a registry like that. In terms of the education and training, there weren't a lot of studies that we retrieved about education and training for workers exposed to asbestos, but the ones that we did find, they were survey-based, and they did find that the influence or the impact of an education and training program was that it did increase awareness. It was focused around building workers. And then finally, there were a few articles about multifaceted initiatives that were identified, and one of them was a systematic review that concluded that the combination of a government ban and elimination of asbestos and control of exposure resulted in decreased incidence of lung cancer and mesothelioma. And then there was one other that basically concluded that it's too soon to determine whether one of these national programs was in fact effective. Diesel exhaust was the second of the carcinogens that we looked at, and again you can see that approximately half of the studies were evaluated. We didn't find any under the diesel exhaust literature that was focused around education and training, so we had studies in the regulatory, surveillance, exposure control. The majority of the studies were focused around controlling exposure, And they were basically looking at the impact of engineering controls, and they were finding that they were effective at reducing the exposure. Silica was the third that we looked at, and the industries that these studies were carried out were mainly construction, mining, and also foundry workers. We found that we found studies in 4 of the 5 prevention clusters. We didn't find any surveillance studies, but we did find that there was studies on the regulatory exposure control, education and training, multifaceted, which you can see on the slide. In terms of the legislative framework, what I wanted to just flag here was that there was a study that came out of Finland that identified that after a new occupational exposure limit was introduced in Finland, and it coincided with the signing of a multi-sectoral intervention, which was the European Network on Silica, which is, as I said, it's a multi-sectoral intervention that focuses on monitoring, training, surveillance. And this was something that we identified here, but also was flagged by several of our key informants as an example of a really effective and really promising prevention strategy. So they found that after that kind of the combination of the new exposure limit and the signing of that multi-sectoral agreement, that they did see a decrease in the exposure. And in terms of the exposure control studies that we found, obviously they were looking at the various types of exposure control measures along the hierarchy of controls. We found one that was looking at examining the effectiveness of a silica substitute. And what they found was that that substitute contained low levels of crystalline silica. So as a result, even though there had been substitution, which is kind of higher up on the hierarchy, that there still was the potential for exposure to occur. So it was not quite as effective a prevention strategy as we might have hoped. I'm going to move on to shift work. And one of the challenges that we had with the shift work literature was that the health outcomes that were being looked at were not cancer. It wasn't the cancer endpoint, it was the other kind of short-term impacts. We included them anyhow. That was mainly the studies that were looking at the impact of exposure controls. We're looking at some of those shorter-term impacts or shorter-term health outcomes. So what they were finding in that situation was, or in those studies, were that administrative controls had a positive impact on both the exposure and the health outcomes. But as I said, it wasn't that cancer endpoint. Occupational asthma is the last, and so some of this kind of touches on or highlights what Paul had discussed earlier. The industries that these studies were focused on were the industries like agriculture, labs, bakeries, isocyanate exposed workers. And what they were finding was that there were positive outcomes in terms of the number of cases and decreased exposures for interventions that were kind of more regulatory in nature, and that engineering controls alone and in combination with personal protective equipment were also effective at reducing exposure. And there were some studies that were highlighting that health surveillance can also reduce or prevent occupational asthma in the way that Paul was talking about, kind of from that surveillance. Just to quickly pull together what this slide is just intended to kind of highlight where we were seeing promising strategies. The ones that I've kind of put in the brackets are to highlight that there were some effective strategies for noise-induced hearing loss, but that there was some questions that were raised based on the context, that they were effective in some contexts but not in others. And then you can sort of see that there were some gaps as well in terms of what we were finding for shift work and asbestos and asthma as well. So here are the takeaways. What we learned from doing this project was that each of these primary prevention approaches plays an important role, and but that each of them has its limitations, and so they're insufficient on their own, which basically which suggests that the multifaceted approaches are more effective. And that although we didn't incorporate a systematic review of the evidence, what we were hearing from or seeing in the literature, and then also hearing from our key informants, was that the outcomes, whether they are health-based outcomes or exposure-based outcomes or behavioral outcomes, that they're influenced by a constellation of factors, so including regulatory frameworks. And one of the key issues that was raised by, sort of emerged in some of the literature and then also was raised by the key informants, was that the regulations can be effective, but one of the big factors is, are they being appropriately enforced? And then other factors that were emerging are things like organizational size, management structures, and culture. And so kind of getting at that whole question of capacity. Larger organizations certainly have the ability to implement some of the control measures, the engineering control measures that are being found to be effective in the literature, but the smaller ones aren't. And so kind of how do you balance that? And then finally, and I think this is no surprise to anyone in this room, the importance of worker engagement and empowerment, and particularly around the effectiveness of the education and training, it's really important to have that engagement and connection, otherwise you're not going to get the uptake. And as promised at the beginning, I would show you the long list of people who were involved in the project. This is the entire research team it was a pan-Canadian effort. It was an interesting group of people to work with and a really interesting project. So as I said, we hope that this will be published shortly. Well, as soon as I submit the paper, in the American Journal of Industrial Medicine, and the report itself will be available from WorkSafe BC. And if anyone is interested, you can give me your name and I will put you on a list and we can make sure that you get copies of the report as well. So thank you.